What's up, guys? It's Nurse Howie, and I just wanted to talk about how to deal with residents. Now, residents are part of the hospital system, and they are very important. Okay, so they're basically doctors that have graduated medical school but are not quite attendings, which are more of like the boss. So they're kind of in the middle, and they're trying to learn their trade, and they were able to finish medical school, so they're obviously brilliant and smart, but they're still having a hard time trying to adjust to the hospital system. Now, again, you can have the most brilliant mind in the world and have the best education as a physician, but you still have to be able to adjust to people and have soft skills. And even if you do have those, you still have to worry about making sure that you can see enough patients and document on them and then choose the right plan. And I tell you, in our industry, our medical industry, it is becoming more and more impossible for doctors to do this. And I can see it whenever I call the doctors. And so more and more people are relying on us, the nurses, to be able to make sure that our patients are safe and that our patients have a better chance of getting a better patient outcome, not just getting into the hospital, getting stabilized, and then going home. No, we need to make sure that our patients are able to get all the treatment that they need, that they're correct, they're given in a timely manner, and that they're educated and set up for success in their own homes so they can just go back to their regular lives. But again, resident physicians are just stretched thin. They're completely stretched thin. They're so very, very tired. They work like 60, 70 hours a week, if not more, and they barely get any sleep at all. So, yeah, that's no small part because of also us nurses when we have to keep calling the doctors. Again, there's just not enough. And I don't know, I'm sorry, but I don't know why you want to be in the position where you are just treated like that. I don't think that these doctors get enough respect. So I do my best to not call them or bother them. But of course, if something happens to the patient and they're neglected, then yes, I will make a phone call and I'll talk to the doctors and I'll say, hey, residents. I don't say, hey, residents. I say, hey, doc, this patient is blah, blah, blah. Can we do something about it? And once we do that, we have to be able to have a sort of a contract between us, between the nurses and the doctors, specifically the residents too, because they are doctors as well. And especially when you're working at night, they're the only doctors that you really contact. They really have very little help, if not from the resident, from the chief resident, because the attending they did their duty, they have paid their dues, and they're being paid big bucks, but they get to go home. Residents don't get to go home. They're the ones that you're talking to, and again, when you're working at night, they're the only people that you're talking to, and that you're asking for, treatment to help this patient. So I'll tell you a little story about what happened to one of our patients, and it's, not too terrible, but it can be quite scary, specifically if you're a new nurse and you don't know what's going on. You have to have these contracts, which are these orders that are written by physicians before you can do anything to your patient. Because without these orders in place, you have nothing to protect you if anything happens with the patient and it goes into court. So you need to be able to kind of guide the residents to what treatments that you want, what medications and PRNs are good for your patient in order for you all to have a safe and good shift. Of course, it's not always evident to the residents because they have a certain way of doing things, but at the same time, you're with the patient 24/7, so your voice counts, specifically if you're a nurse, or really any bedside care, whether you're a technician, an LVN, or anybody that's close to the patient, but definitely nurses. So let's talk about that. Okay, story time. So I had a patient that was prone to seizures, and this patient was even more difficult because he couldn't really speak. That was probably because he has some kind of a disorder where he was found that he was unable to speak. There was some sort of trauma going on, and so I just couldn't get anything out of him. And he spoke sometimes, but when he did, it was nonsensical. So I couldn't get anything out of him. So I couldn't really get a good conversation with this patient, is what I'm trying to say. And because of certain other reasons, without going too much into it, the patient had to be able to, or the patient really couldn't swallow very well. And if a patient can't swallow, we're really worried about them choking. So if they're not otherwise intubated, then we take a thing, we take like this long straw tube called the nasogastric tube, and we put it in the patient's nose, and it goes all the way up, and then goes back down through the back of the throat, and then goes down in the stomach. Now, kind of think like the Mummy kind of movie kind of a thing. So it sounds bad, but it even looks worse when we're putting it in, because the guy's like, people are like choking, and it was very traumatic for both me and my first patients when I first started doing it years ago, but now it's just like nothing. So, but anyway, the patient, if they can't eat using their mouth, that's the next thing that we're going to try. We're going to try to put the tube in so that we can feed them, and we'll usually, the registered dietitians, which is this awesome, amazing team of people that can calculate exactly how much the patient needs to eat in order to stay healthy. And I kind of wish they worked for me, because I need a good dietitian. But anyway, science-wise, they're very great, and they calculate everything down to the T. And then you take this bag of food that they recommend to you, and it's basically just like a giant milkshake, or I don't know whether it has milk on it, but there's a shake, and then you put it on a tube that's hooked to the nose and then goes down in the stomach, and that's how you feed them. But this guy was just not liking this tube. Now, usually when you put in an NG tube, a nasogastric tube, definitely is going to be, you're going to need a few hours to really get used to it and not worry about it. But some patients just cannot handle putting a nasogastric tube in their nose and in their mouth. They just kind of, they just kind of like cough it all out and just take it out of their So it's really frustrating, because you really want to feed these patients. There's no other way they can eat besides doing another method called a TPN, total parenteral nutrition, but we'll talk about that in a different video. But this way is the next way that they can eat, and they have to eat if they're going to get any better and get out of the hospital. So, but yeah, the patient was just not having it, and the patient was also restrained, which made it even worse, because confused patients that are restrained are very, I feel like they're in a lot of danger, because you really have to keep an eye on them, make sure they don't hurt themselves. But you don't want them pulling out their IVs and the nasogastric tube, so you have to restrain them. But then they can't tell you if they're in pain, so it's really just a trifecta of terribleness. So anyway, I was watching this patient, and the patient was hooked up to, like these EKG leads, and also a pulse oximeter, which we put on their fingers to make sure that the patient was breathing well. But the patient was not breathing well, and I did not need a machine to tell me that this patient was not doing great. So I was telling the doctor, the patient was going like this, like it was like the poltergeist. It was terrible. And pretty soon, the pulse oximeter machine I saw was starting to drop, and if it drops below 90%, then you just really want to attend to your patient, because they can't breathe, and breathing in airway is the first thing and the first top priority for your patient. So I call the doctor and say, hey, this is for a patient, bed, yada, 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 and he has this, and this. He's currently getting a nasogastric tube feeding, but he cannot tolerate it. He is shaking in bed. He's pulling against his restraints really hard. He's choking and yelling. I put the head of the bed up, but I can see a lot of spit really gathering on the tip of his throat. And I'm not currently feeding him with anything. There's no shakes that are coming through the tube for feeding. So I don't know where all this spit is coming from. And The one thing that I can tell you, doctor, is that the tube is pretty low. It doesn't seem like it's fallen out of the tape that we've hooked up with the patient's nose, but it's approximately at let's say 60 centimeters. And I didn't get any previous centimeter from report from the previous nurse, so I'm not quite sure if the tube migrated, but if it did, I'm really worried about our patient's airway and their safety. Would you like to do something about it? And the doctors were like, I don't know, I don't have time right now, but just like tell me, like, what do you want to do? So usually when you give these reports on the phone, you want to be quick and concise. One of the last parts of the concise report that you want to give the doctor is that you want to give a recommendation. And so I told the doctor, hey, so if you don't want to do anything else and you want to come see the patient, I recommend that you either tell us to remove the tube, or I recommend that first we can preserve the tube placement, but we need to have a chest x-ray or an abdominal KUB, which is another kind of like an abdominal imaging, if you want to see exactly where the nasogastric tube is, and then I can just migrate it down. And the doctor said, yeah, you know what? Yeah, let's do that, and I'll write the order, and we'll go ahead and try it. So while the patient's still going, I don't know why I'm laughing, but it's just really just so comical, but also really kind of gut wrenching, but also you're terrified, you know. But I've seen this before, and the patient was desaturating his oxygen low, but it wasn't so low that it couldn't preserve life. So, you know, it was definitely dangerous, but nothing that I couldn't handle otherwise. So I'm waiting for this order to go through. So just like I explained, before you can touch the patient or do anything, you have to have a doctor's order as a nurse. Otherwise, you are completely just doing whatever you want to the patient without any doctor support. And if that goes into court, then you're in trouble because you're basically assaulting the patient because you don't know what you're doing compared to what a doctor would. Now, in real life, you do know what you're doing. You probably have more experience than the baby doctors that are on the phone, but you know, the courts aren't going to support that. You know, nobody's going to support you if you're just kind of, you know, doing everything willy-nilly. So the orders are there to protect the patient, but they're also there to protect you. So I'm waiting for these orders to be written down, and I see that she's writing these orders for me and for them to order a chest X-ray so we can figure out what's going on. Because if the nasogastric tube goes up out of the stomach, it could start to kind of trickle tube feed or milkshake into the lungs. But again, this patient wasn't getting any tube feeds. But still, maybe the patient was just having some kind of a reaction, activating the salivary glands too much. But either way, there is water in there, and if it goes into the wrong tube, and the patient could choke, or they could desaturate their oxygen. So I needed to do something, and the orders weren't put in. So finally, I called again. I said, "Hey, doctor, I'm still waiting for your orders for the chest X-ray." And then I noticed that you discontinued it. Is there anything that's wrong? Because this patient is really uncomfortable. And a guy ended up answering the phone this time, and he goes, "Oh yeah, well, you know what? I saw about the patient just discontinued the nasogastric tube." And I said, "You know what? That works fine too. If they don't want to get the chest X-ray to come up, which is this big machine, but they can wheel it in. It's a portable chest X-ray machine. If they don't want to bother bringing that up, and they discontinued the order, and they told me that they wanted the patient's nasogastric tube to come out, then well, what else would I do?" So, my patient at this time was really satting terribly low, so I immediately went over to the patient and just yanked the tube out. And it doesn't hurt as much as it does putting it in, so it was just easy peasy. The patient started to stabilize, and his airway went back to normal, eventually, pretty quickly. Then something happens. I go home thinking that everything is fine, everything is clear, and then I get an email from my nursing manager that says one of the doctors claims that I took out the nasogastric tube without their permission. And I'm like, wait a minute, you told me verbally
that you would write an order. I was thinking that this is what I would say to the doctor, that you would write an order for me to remove the nasogastric tube. But their claim, or his or her claim, was that because I removed the nasogastric tube, the patient had no other way to eat. Even though he was, I'm sorry, I forgot to mention this, the patient was getting total parenteral nutrition. He was getting food from his veins, to his veins. So he was getting nutrition. But I don't know, somebody was out to get me. So baby nurses, be careful. Don't try to do anything to the patient without an order in place. And I made a, kind of a gray mistake, because nursing is not black and white. Nursing is gray. If it was black and white, we would be replaced by robots like that. But I had trusted that the resident would write the order saying to remove the nasogastric tube, but it was my fault for not checking it and bugging them to write the order. Because when somebody from the outside came to investigate, they saw that there was no order to remove the nasogastric tube, and they were upset. And they were upset at me because they think I just did it on my own will. I wanted to, but I didn't. I had a verbal order. But that verbal order wasn't put into concrete in the computer. So I was mad. So I sent my nurse manager a very lengthy email explaining all the steps. And she believed me, thank goodness, that she is a manager that supports her staff, even if they're travelers. Because I told her, I took a screenshot of the orders that they made about the chest x-ray, which they turned into a KUB imaging, and then they discontinued it 8 minutes later. So I told her, why would a physician order a chest or imaging x-rays and then just immediately cancel it if they didn't want to tell me to just remove the nasogastric tube? So she's like, well, that makes sense. And also the patient was really in acute distress. I needed to save the patient from him losing his breath. I needed to save his life. So yeah, I'm going to take that little, straw out of his nose so that he can breathe better. Don't get mad at me and try to blame me for trying to make the patient more comfortable. We could always put in the NG tube an hour, maybe 2 hours later, and that's what they did anyway in the next shift. So there was definitely some bad blood. So nurses, I'm going to tell you, you got to watch out for these residents. They're really trying their best, and most of them, I would say about 98% of them, are really nice, and they do a wonderful job. But watch out for the 1 or 2% of those that will try to throw you under the bus if you don't have an order stating what you can do to the patient, what you can give them. They're basically a set of instructions, and you need to follow these set of instructions. And if you can't follow them because it's too much of an emergency, and you can't wait for the doctor to write the order, or they say that they're gonna, but they don't, you need to cover your butt. And I should really be listening to this advice. It's my own advice, and sometimes I just forgot. So now I'm really kind of on the ball with these orders. You need to write these orders down, and if you don't, then maybe in another video I'll talk about how to write retroactive orders that causes you, or causes the resident or any other physician to have to sign it because they can see it and they have to sign the order, or they can decline it, but it's up to you to make sure that it's signed before you do anything to the patient. So, these are the iffy ins and out and the gray area about nursing that really kind of scared a lot of people. Scares me too, and really kind of wears me down because nobody wants to see an email from their nurse manager when they're on their day off. Okay? Okay? Alright. So, nurses and patients, I hope you guys are safe. Doctors, nurses, let's all do better. I will try to do better. If you guys have any questions, comment below, like and subscribe. Nurse Howie out!